Welcome to the November 2024 LACNETS educational event. I'm Kavya Velagapudi, Executive Director of LACNETS.
I'm Lisa Yen, Director of Programs and Outreach for LACNETS.
And I'm Heather Davis, the Associate Director of Advocacy and Outreach for LACNETS.
Today's presentation is on palliative care for neuroendocrine cancer. A special thank you to our supporters, Novartis, Ipsen, ITM, Crinetics, Curium, and Axilexis. LACNETS stands for Learn, Advocate, Connect, Neuroendocrine Tumor Society. Our name also states the mission of our patient advocacy organization. The LACNETS staff includes Lisa Yen and Heather Davis. Our board includes Donna Gavin, who is the sister of LACNETS founder Giovanna Joyce Mbasi, and NET patient Mary Dunleavy, who has been living and thriving with NET for nearly 20 years. We're excited to share that LACNETS is partnering with the Carcinoid Cancer Foundation, or CCF, to provide support line assistance and other programs. For more information, visit lacnets.org/supportline. Now over to you, Heather.
Thank you, Kavya. Our YouTube channel features over 400 educational and wellness videos, testimonials, and podcasts. Use our playlist to find patient stories, information on types of PRRT, liver-directed therapies, chemo and immunotherapy, clinical trials, nutrition, imaging, and our annual conferences and in-person events. And you can also find our videos by topic in our video library on the homepage as well by going to the Learn tab. Follow LACNETS on social media. We are on Facebook, X, and Instagram with the handle @LACNETS. And be sure to add us to your Save Sender email list. I'd like to remind the audience that LACNETS webinars are created for educational purposes only and do not substitute for medical advice. The views shared in this webinar are the experts' personal opinions. Please contact your medical team with questions or concerns about your individual care or treatment. As special note, this presentation will mention and address death, dying, and sensitive topics regarding end-of-life care, including hospice. And now I'll hand it over to Lisa.
Thank you, Heather. I've been supporting my husband, who was diagnosed with advanced metastatic neuroendocrine cancer in 2015, and together we aim to stay informed and engaged with clinical trials as possible treatment options throughout our journey. We understand that one of the challenges is not just finding out about trials, but finding information about specific clinical trials that is easy to understand. And this is why LACNETS created a clinical trials guide, an easy-to-use educational resource that features several key clinical trials for neuroendocrine cancers. You can browse the site by the type of neuroendocrine cancers or treatments, and when you go to the individual trials, you can find brief patient-friendly videos and information about each trial. We hope our clinical trials guide can help you better understand clinical trials that might be available for you. I'm pleased to introduce our speaker for today, Dr. Chandana Banerjee. Dr. Banerjee is the Dean, Director, and Designated Institutional Official for Graduate Medical Education at City of Hope. She is also an Associate Professor in the Department of Supportive Care Medicine, specializing in hospice and palliative care. She developed the City of Hope Hospice and Palliative Medicine Fellowship, and she also established the Cancer Pain Rotation for Kaiser Permanente Los Angeles Hospice and Palliative Medicine Fellowship, which is now part of the core curriculum for Kaiser Permanente Southern California Hospice and Palliative Medicine Fellowship Program. Dr. Banerjee also developed and directed the End of Life Symposium, which was first held at City of Hope in 2019. Dr. Banerjee holds multiple leadership roles in this arena. Her bio is quite extensive and impressive. She's also written and published numerous articles and book chapters. She's a frequent speaker at national and international conferences. I first met Dr. Banerjee 5 years ago when she spoke at our LACNETS 2019 Neck Cancer Day Symposium that was held at City of Hope. And at that symposium, I shared with her my dream of starting a virtual neuroendocrine cancer caregiver-only support group. She said, "Let's do it." Soon after that, in 2020, we launched this support group and it has been thriving ever since. We're grateful for her commitment to the neuroendocrine cancer community. And one fun fact about Dr. Banerjee is she loves to write poetry. She's published 2 books of her poetry collections. Her first collection, Ashen Leaves, was published in July 2020, and her second book, Neruda in Bed, was published in November 2021. Welcome, Dr. Banerjee. We're really grateful to have you here with us today.
Hello, everyone. I'm Dr. Banerjee from City of Hope National Medical Center, and I'm honored to be speaking today to you as LACNETS talks about the role of palliative care in neuroendocrine cancers. Thank you very much for having me on board. So let's jump right into this. The role of palliative care is very confusing to many people. It's an upcoming field. However, no one can really understand, is it appropriate for me? Is it appropriate for my disease? So let's delve into it, and hopefully you can take a look at it as to how it applies for neuroendocrine tumors and even possibly other diseases that might be affecting people with neuroendocrine cancers. So I have no disclosures. And just to let you know, this is where City of Hope is. It's near Los Angeles in a place called Duarte, and that's our main hospital research center. So if you look at really the objectives for today, we're going to look at defining in just one slide what neuroendocrine cancers are, what these tumors are, just for those that are new to NET. We're going to define palliative care. We're going to look at the difference between palliative and hospice care, which is often confused as one. We're going to define what quality of life means. We're going to understand the importance of integrating palliative care in patients with neuroendocrine tumors. We can review some of the symptoms that require palliative care, and then just look at other palliative care options for NET patients. When you look at neuroendocrine cancers and tumors, right, these are abnormal growths that develop in the neuroendocrine system, which is made up of nerves and gland cells. Neuroendocrine cells are throughout your body. Neuroendocrine tumors begin when there are small, subtle changes and mutations in the DNA of neuroendocrine cells. These cells often produce hormones. These tumors can occur anywhere in the body, mainly lungs, the appendix, the small intestine, the rectum, and pancreas. And these tumors can grow slowly or sometimes aggressively and very quickly. So as you can see, neuroendocrine tumors or neuroendocrine cancers affects really sometimes your entire body. And that's where the palliative care team and the palliative care approach can be very helpful in managing some of these symptoms for patients. So what is palliative care? One of the myths people often have is that they think palliative care is for people that are dying or towards the end of life. And hopefully I can dispel some of the myths that palliative care has so far. So palliative care is a fairly new subspecialty in medicine compared to many of the other subspecialties, but it's being used more frequently these days. It helps people with serious illnesses or chronic conditions to manage really their symptoms, stress, and enhance their quality of life. It can be provided at really any stage of a serious illness, so at diagnoses all the way to the end of life. And it can be used when other treatments are being offered. You do not need to stop your regular treatments as you get palliative care. It can be given in any settings, be it home, hospital, or even in a nursing home. It's really up to where the patient wants it and needs it. So let's look at the palliative care basic principles. And I love the fact that these days you can go anywhere on the internet and Google AI will really give you a wonderful summary. So if you need to get more information, please use AI to our benefit is a good thing. So when you look at the goals of palliative care, you look at improving quality of life, reducing symptoms like pain and side effects caused by the disease itself, or maybe the treatments causing the side effects. The focus should always be on patients' needs, the values, and goals of care. Services that are provided are physical, emotional, and spiritual support, including counseling, support groups, and referrals to mental health providers if needed. Who provides palliative care? It's a team of doctors, specialists in palliative care, nurses, and other specialists, including pharmacists, physiotherapists, and volunteers. You often have social workers that are assigned to the team. When do you want to consider palliative care? Really, at any stage of a serious illness, at the discretion of the patient and their physician. I often recommend that patients ask physicians to include the palliative care team within the first or second visit of the diagnosis. Coverage is almost always covered by insurance, including Medicare and Medicaid. Compared to that, when you look at hospice care, you can see some of the same services being provided by hospice care, similar to palliative care. However, this program provides services for those who are nearing the end of life. It provides physical, emotional, social, and spiritual support for people with serious and terminal illnesses. The goal of hospice care is to help patients be as comfortable and alert as possible to improve their quality of life. There is an eligibility criteria to sign on to hospice, and patients usually have to have a life expectancy of 6 months or less with a terminal diagnosis. So, who is it really for? It's these people with serious illnesses who are nearing the end of their lives and have stopped treatment to cure or control their diseases. It provides, similar to palliative care, medical, psychological, and spiritual support, but it also provides equipment and supplies and medications to help with movement and breathing and other aspects of the disease. It can take place at home, in a hospice center, at a hospital, or a nursing home, essentially anywhere a patient defines it as home. It's provided by a team of healthcare professionals and volunteers, very similar to a palliative care team. It also includes support for family members, just like the palliative care team, but it also includes bereavement counseling after the patient dies. So it's important really to understand what the palliative care team looks like. And I found this amazing infographic by Chipla Palliative Care, which is in India. And I think it captures really the holistic aspect of palliative care. At the center, you can see you have the patient and the caregiver. And you can see from this image that they experience together a multitude of effects, such as physical pain, spiritual pain, psychological pain, and social pain. Obviously, just a doctor is not enough to address these. And for palliative care to work appropriately, you need a team. You need that holistic approach. So you often have doctors, you have pain specialists, you have medical social workers, nutritionists, physiotherapists, support teams, volunteers, and nursing teams that often work together at the same time or differently to address every aspect of the patient's disease, as well as support the caregivers and the family. Why is it so important to have that team in place? The importance is because quality of life is drastically impacted anytime a patient has cancer, especially in a cancer like neuroendocrine tumors. Quality of life is individual to the patient. What looks like quality of life to one person may not be the same to the other person. And this should be discussed during diagnosis and throughout the disease course. Chronic illness significantly impacts a person's quality of life, affecting physical, mental, and social well being in many ways. When you look at physical limitations, things like pain and fatigue, mobility issues, and changes in appearance can really influence how a patient feels and can cause emotional distress, can cause depression, anxiety, feelings of isolation, and anger. Finances are always burdensome. No one plans for a serious illness. So, when it comes to being diagnosed with a serious illness, financial burden is of utmost importance to keep in mind. Medications, doctor's visits, diagnostic tests, and hospitalizations often cost a lot. Social isolation is huge in patients with chronic illness such as NET. You have difficulty participating in activities because of certain symptoms that might debilitate you. And you might have a loss of connection with friends and loved ones. Sometimes friends and loved ones may not understand what you're going through and may not reach out to you appropriately or at the right times. Work can be an issue. You may or may not be able to work, and changes to work to cope with physical limitations or financial difficulties are a huge possibility. Family members and caregivers are equally affected by the patient's disease. They may be influenced by the chronic health problems of a loved ones, and you'll see, we'll cover in a few slides later, caregiver burden is a huge aspect of making sure that palliative care is successful. So that brings us really directly the role of palliative care in neuroendocrine tumors. There's this incredible article that came out last year, and I highly encourage all of you to read it. It's called The Practical Considerations When Providing Palliative Care to Patients with Neuroendocrine Tumors in the Context of Routine Disease Management or Hospice Care. And they cover a huge aspect of what palliative care looks like in the face of neuroendocrine tumors. And I'm going to cover some of that in this presentation. I've cited the article below this slide, so please feel free to take a look at it in depth. So the principal pillars of palliative care in NET are symptom management with medication, integrative practices, palliative procedures, and NET-directed treatments. Let's look at these all in individuality. But before we do that, let's think about the distressing symptoms in neuroendocrine tumors. You can have things like pain, neuropathy, vomiting, anorexia, GI distress, malabsorption, pleural effusions, anywhere all the way to hepatic, which is liver obstruction, and partial small bowel obstruction. The interesting thing with neuroendocrine tumors is that these symptoms may present a few at a time, or they can present in multiple factors. And as the disease progresses and patients start declining, you can have more of these symptoms presenting all at once, which makes it very difficult for patients and loved ones to see the family and the patient suffer through it. So how can we manage them? So palliative care and its team of doctors and specialists really work with medications to combat some of these symptoms that the disease can provide. You have things like opioids and co-analgesics like gabapentin to curb the pain. You have stimulants when there's fatigue, antidepressants for people that are going into depression. Anxiety is a huge aspect in NET, and anxiolytics can help. You have carcinoid syndrome management medications specifically that really help with the symptoms, things like somatostatin. Ursodiol is something that can help with diarrhea from bile duct obstruction. You have pancreatic enzyme replacements that can help with diarrhea from pancreatic insufficiencies. You have antiemetics that can prevent nausea and vomiting. You have other general anti-diarrhea medications. For those patients that lose appetite, there are appetite stimulants. And because the gut is so affected, the intestines are so affected, gut antibiotics can be helpful in restoring some of the flora that can abate some of the symptoms that you have. Really looking at integrative practices, these are up and coming and should be used by patients more than they have in the past. These patients can highly benefit from acupuncture, which has been shown to help with nausea, fatigue, and pain. American ginseng is often used as a stimulant. You can look at cannabis that helps with appetite and anxiety. Massage therapy is often helpful when it comes to pain. Ice, heat, relaxation, and exercise are all a combination of the therapies you can give to cure your muscles that are affected, as well as the fatigue that comes with neuroendocrine tumors. And again, as in many of the serious illnesses, NET has many nutritional issues. Nutritional issues in carcinoid syndromes cause malabsorption, and supplements here can really be helpful to make sure that the patient is maintaining a healthy weight appropriate for their disease. When you look at palliative procedures, these are again based on the type of NET that the patient may have and the type of symptoms that might occur. To note, not every palliative procedure is for every patient, and these procedures really must be taken in context to where the patient is in their disease course, how progressive the disease is, and what ultimately looks like the quality of life for the patient. So you have surgery that can debulk or remove sites of the tumor causing symptoms. Paracentesis is often used for ascites, which is a collection of fluid. Thoracentesis, again, is used for pleural effusions or accumulation of fluid in the lungs. You can use biliary stenting for any kind of hepatic or liver obstruction. And then you can use gastric decompression as a procedure to take care of partial small bowel obstructions. Moving out to net-directed treatments. This is a field that has advanced significantly in the last few years, and all these therapies available for patients, and many of these are deployed by patients. So you look at chemotherapy can be used in patients even as a palliative mode to really help with the symptom management. Things like 5-fluorouracil are used often. You have immunotherapy, which are targeted. You have radiation. You have targeted therapy that is specific to a certain tumor location. You have PRRT. You have surgery. You have radiofrequency ablation and hepatic artery embolization. What's important to know in NET is that many of these NET-directed treatments often are also palliative in nature. They help really alleviate some of the symptoms that are being caused by the disease and can often help in the quality of life of a patient. So that brings us to the importance of caregiver burnout, right? Caregivers are an important aspect of caring for someone with a chronic illness. In a disease such as neuroendocrine tumor that can last for multiple years, caregivers are really important in making sure that the patient goes through this journey appropriately and in a holistic manner. But it's important to know that caregivers often suffer significant burnout. They suffer a caregiver burden, they have caregiver stress, they can self neglect their own health. There is physical exhaustion that can really be in addition to the exhaustion caused by caring for themselves, the patient, and the extended family. There is emotional exhaustion because they may not have other people to talk to about caregiver aspects. But there's something called caregiver respite, where there is a safe space that caregivers can create for themselves. So, what does caregiver burnout look like? You can be easily flustered or frustrated, even with the patient sometimes. You can get forgetful or foggy because you're having to remember so many things, not only for the patient, but other aspects of your life. Extremely tired, being very quick to get angry, often feeling anxious or depressed. You might become uninterested in things that you used to do before you became a caregiver. In fact, caregiving might become what you do all the time, 24/7. And sometimes you might feel hopeless or helpless because if you don't care for the patient, you might start feeling guilty as to how will the patient be taken care of. So, steps you can take in your NET journey is something really that I advise as a palliative care physician to everyone that I meet. The important thing is that you have to ask your doctors all the difficult questions. Communication and transparency in communication is of utmost importance in something like neuroendocrine cancers because they can be slow, they can advance rapidly, they can be asymptomatic for a while, but the uncertainty is certainly there. And so you need to make sure that you know what next steps look like. You know what the disease looks like as it progresses. You need to understand what you need to plan for. You need to get your caregiving team and your family involved in these discussions with your doctors so you're not going through it alone. You need to ask for the palliative care team to get involved. Like we said, palliative care is not hospice care. It can be started at any time during your disease. My recommendation is often to get palliative care teams involved, usually during the second visit, so that they start to get to know you and your family better. They start understanding your goals and your quality of life concerns. They start understanding your values. And if things get complicated, they can be partners with you in helping you decide what's right for you in terms of treatments or healthcare choices. You should ask for support groups in your healthcare and community settings. Palliative care can often identify these for you with their social workers and the groups that they may have already in place. LACNETS is an excellent source, and it wouldn't have been if we didn't have our palliative care team at City of Hope that I would have been introduced to this wonderful group. You need to find other groups like this in your healthcare and community settings so that you can be provided care holistically and that your family and you have all the support that you can get beyond your hospital and your healthcare primary team. You need to ask for resources. The internet has a myriad of resources. LACNETS provides incredible resources. There are other resources around the country and in your hospital setting that you need to ask for. If there aren't any resources, you need to have them recruit resources so that it can help you and other patients like you. What's important is that you also identify your caregiver community. Caregivers and your family members that care for you and your loved ones that care for you, including your friends, are important in your journey for neuroendocrine tumors. You do not have to go through this alone. It does not have to be scary. In fact, having caregivers make sure that your quality of life is already enhanced because caregivers prevent you from having isolation, prevent you from going into that cocoon and thinking that you have to go through this alone because you don't have to. It's very important that patients, as well as their family members and caregivers, identify what quality of life means to the patient and means to the loved ones. Sometimes quality of life might mean doing everything that you were able to do before you got the diagnosis. And if that's the case, you need to figure out ways and figure out symptom management techniques that'll help you do that. But sometimes quality of life means that you will take what comes to you and appropriately handle it, that you will scale down on certain things that you did before, but you will still enjoy the important things in life to you. This needs to be identified and it needs to be assessed continuously as you go through your NET journey. What quality of life meant for you when you got diagnosed may be very different a few years or months down the line. And of course, it may be very different for you when you come towards the end of life, if that's where the disease progresses. The most important thing I say for any kind of chronic illness, including NET, because of the uncertainty of neuroendocrine tumors sometimes, is to start advanced care planning. What I often find is that patients have advanced directives and have living wills that have been done years ago. It's a good idea to review these frequently, at least once a year, if not twice a year, to make sure that everything is appropriately put in place. The last thing a patient wants to do is have the emotional and burden and stress of having to do an advanced care plan or having to do uh, their directives such as CPR or DNR when they are sick. All these are best planned when things are not in stress mode and early on and reviewed often enough. As a palliative care physician, my biggest hope is that anyone with NET really understands that palliative care is here to partner with you. This is a team of medical and non-medical specialists that can really help every aspect of your journey. It can help you navigate the journey. It can help you with symptoms. It can help your family with burdens and caregiver stress. And ultimately, it can enhance your quality of life. And I hope that's what you get out of this presentation. And with that, I'd like to thank LACNETS for allowing me to come onto this webinar and discuss palliative care with you. Thank you, everyone.
Thank you, Dr. Banerjee, for that really enlightening presentation. I really appreciate all the helpful tips and the guidance, this overview on palliative care, which is really a topic that we need to learn a little bit more about that we often don't talk about. So just for the audience, just a couple practical things. This question and answer session is for educational purposes only. It does not substitute for medical advice. Please do remember to talk to your medical team with questions or concerns about your individual care or treatment. We will try to get to as many general questions as possible on the topic of palliative care that is in the area of Dr. Banerjee's expertise. And please note that we will address general questions only. Dr. Banerjee will be answering questions generally, and she cannot provide specific feedback on your individual situation. So again, thank you, Dr. Banerjee, and we will get to some questions now.
Great. Thank you, Lisa. It's such an honor.
So the very first question, just something practical. What makes someone eligible, or what's the criteria to access palliative care medical treatment?
So palliative care really is something that is used when patients have a chronic or a serious illness. It's a step beyond your basic internal medicine criteria. So, for example, let's say a patient gets diagnosed with a cancer or a chronic lung disease or a kidney disease. These are conditions that are going to be long term and impact your quality of life and cause a lot of symptoms along the way. And that's what makes a patient eligible for treatment, for medical treatment. There's no specific criteria per se, but anytime a patient gets diagnosed with a serious illness or a chronic illness, it's a very good idea to get them involved with palliative care.
Okay, thank you. And you mentioned hospice. I know with hospice, and you mentioned this in your talk, it's limited to 6 months. How long can someone receive palliative care? And is it limited to 6 months like hospice?
Right. So there's one key difference. So palliative care, first of all, has no time frame to when you can get eligible to it. You can get eligible to palliative care when you first get diagnosed. Let's take, for example, a patient gets diagnosed with a NET. And you know that with this disease, there's going to be a lot of symptoms that require more specialists and other support systems. You can immediately have your palliative care team work with you and provide you palliative care. What hospice care is that you become eligible for it when you have 6 months to live. So it's not that hospice is limited to 6 months. When a physician gives you a prognosis or a life expectancy of no more than 6 months left, that's when you can actually become eligible for hospice. Now, that's not to say patients die within 6 months. Some patients go on to live beyond that. Look at President Carter, for example. He has surpassed his time limit for hospice and he's still alive. And what's important to know that even though we say you have to be 6 months or less with life expectancy to sign on to hospice care, it's a system that can reevaluate you as time goes on, and which could mean that once you sign up for hospice care, you may die before the 6 months is up, or you could live for more than 6 months, which at which point the hospice team would reevaluate you and determine whether you're still eligible for hospice or whether you need to be transitioned off of hospice just to plain palliative care. Does that make sense?
Okay. Yeah, so it's like a continuum, possibly.
It's like a continuum, and palliative care has no start date or end date. Some patients decide that they don't want to sign on to hospice and they end up receiving palliative care throughout the end of their life till they die.
A follow-up question to this. I know in your slides you were talking about all the different treatments people can still be getting, chemotherapy, targeted therapy, PRT, and all these treatments. So can you just kind of clarify a little bit, how come someone can get it while they're on palliative care, but then they can't get treatments when they're on hospice?
Right. So the goal of hospice care is really to work with you towards the end of your life. So that 6 month mark and beyond, right? Till you die. And the goal of hospice care is pretty much quality of life, but with the idea that you no longer have treatments that are curative available to you, or because of the disease or the symptom burden that the treatments have caused, you've chosen not to pursue any curative treatments, right? So the goal is really making sure that you're comfortable and that your quality is as best as it can be during your dying days, whether it's 6 months or 3 months or 8 months, right? So that's why hospice does not enroll patients that are receiving curative treatments, because it's a different philosophy. But palliative care is not end of life care. Palliative care in general, if you look at the root word palliative, is to palliate, right? To alleviate. It's a healthcare specialty that helps with managing symptoms that are either caused by the disease itself or by the medications that you're receiving to cure the disease. And what palliative care does is make sure that it provides the appropriate care to address each of these symptoms, so that these symptoms and the burdens of the treatments don't affect your quality of life, or can at least help mitigate some of the side effects that are caused by both the disease and the treatment.
I'm glad you explained that. Thank you for clarifying. Um, and also, how does someone find a palliative care doctor? This question comes up a lot. Is it important to have a palliative care doctor that understands NETs?
So palliative care is a very wide discipline. Palliative care specialists such as me are trained to treat really all the possible symptoms and side effects that many diseases can give. So whether it's a serious illness or terminal disease, these physicians are trained in management of symptoms and side effects and providing holistic care. So it doesn't necessarily have to be a palliative care specialized in NET. However, it does help for a patient's physician have experience with patients that are facing that, just so that they can better understand the patient, better understand the disease, better understand the side effects and the treatment side effects that are going to be coming up. It helps plan better, but that does not mean that you restrict yourself to a NET specialist or NET palliative care specialist if one's not available in your area. I will say this, that most major medical centers these days have palliative care in their systems, and palliative care specialists and palliative care teams. If you're in a rural part of America, that may be something difficult to get. So when you are not in an area where there's palliative care systems, it might be helpful for you to ask your health system or your doctor that's treating NETs to maybe connect you with a palliative care physician outside of the system or in a different location that can possibly even do a virtual visit with you, find someone in the area that can do a house call with you to manage your symptoms. There are many ways to get palliative care physicians on board. Palliative care as a field is growing, and there is a movement to increase palliative care in rural areas. So hopefully the need to be in urban areas is not going to be something that's a requirement for getting palliative care. We want to make sure that everyone, everywhere, has access to palliative care.
Yeah, we hope so. And are there any other terms, any other titles other than palliative care that these doctors might be called?
Yeah, so thank you for bringing that up, because I'm still so biased with palliative care as a field. Often palliative care is also called supportive care medicine. It gets a little confusing because sometimes people don't understand what exactly supportive care means. But in a sense, it's pretty much the same as palliative care. Supportive care medicine sort of encompasses all the various aspects of palliative care that you see, that team model that I talked about, the social workers, the psychologists, the nutritionists, the other physicians, chaplains sometimes. All these are supportive services, and they provide supportive care, and supportive care medicine provides palliative care to the patient.
Okay. So perhaps people can ask their doctor or their institution if they have palliative care or supportive care.
Supportive care medicine.
Thank you for that answer. Thanks for that clarification there. So, sometimes we hear people talk about doctors not necessarily communicating with each other. Are there any tips about maybe getting your palliative care to work with the primary care doctor, oncology, pulmonary, other doctors involved?
So that's the beauty of palliative care and palliative care specialists. They are really the middleman to making sure that your entire teams are talking to each other. That's because the patient's interest is at the core of palliative medicine. So they not only become a team that manages your symptoms and helps with other aspects of your healthcare, but they also become your partners in communicating to the various other teams that you're working with. For example, as you say, oncology, pulmonology, to make sure that what they're offering aligns with the patient's goals and values. And when times are difficult, they sort of help the conversation, and they help put the patient and the teams at ease to come to difficult decisions if necessary by being those partners in the care together.
Yeah, partnering together. Um, so some, especially right now, there's concerns about what might be coming around the corner. How are you dealing with concerns of some patients in palliative care over maybe possible 2025 plans with medical or financial assistance reductions?
I think this is a very difficult question, and it's something that is so much in transition. As a society, we do need to look at what really is important in healthcare for the entire population. We know through COVID and through other examples that palliative care has really helped reduce the cost of care, especially at the end of life for patients. It has helped reduce certain hospitalizations. It has brought costs down for patients when it comes to their treatments. That's because palliative care team addresses the entire patient and addresses all the aspects of healthcare. What I say is that we can't always control what's going to happen on the legislative or the policy aspects of Medicare or with financial planning. However, what we can do is partner with palliative care teams early on so that these concerns are addressed simultaneously. Palliative care often has been a team of people that has helped find resources for many patients that do not have the ability to pay for the treatments. They have found resources for patients. They have the time to sit down with the patients and look at the patients' financial, social, psychological aspects of care. And that's where I think we need to make sure that we're using palliative care resources to the best of our ability to make sure that these reductions are something that don't impact the overall care for the patient.
Yeah, so using our voice and advocating for what we need. Let's dive into some of the common topics and some of the things you have mentioned in your presentation. What can be done to manage pain?
So, pain is so multifactorial, right? Pain is not only the physical pain that you're getting because of the tumor or the disease itself, pain can be caused by the medications that you're getting to cure the disease. But pain can also be psychological and emotional, that's causing stress, and anytime you have distress and anxiety, we know that pain receptors are upregulated, and that patients feel more pain when they're more stressed or anxious. So, what can we do for that? I always say try everything that's there, but to start with, first of all, making sure that you are removing as many de-stressors out of your life as possible. If there are situations and if there are environments, or even I would say people that are causing you stress that can increase your pain, isolate or separate a little bit from them. I think remove them from your universe a little bit so that you have the space to heal. Pain often is tied to a holistic healing, and you have to be able to manage all aspects of pain. When it comes to specifically pain that is, due to the disease or due to the neuropathy or the nerve exacerbations that are from the disease, there are many medications. If you look at the World Health Organization tier of medications, you start off with your basic non-opioids, which are things like ibuprofen and acetaminophen. And they may be okay at the beginning of someone who has neuroendocrine tumor. But as the disease progresses, you may need some opioids to it. So you can have medications in the second tier, which are opioids, weak opioids with ibuprofen and acetaminophen in them. But if that's not enough, then you do go to the other medications like opioids, morphine, Dilaudid, fentanyl, OxyContin. These are all opioids that are really powerful at managing the pain caused by diseases and by tumors. There's other coanalgesics like gabapentin, and pregabalin, which are neuropathic pain medications. You know that because this is a neuroendocrine tumor, neuro symptoms are very prominent, and these medications can really be helpful in making sure that the pain is kept to a minimum. Other than that, I would say always employ things like, be in an environment that is zen. Heat and ice for different types of pain works beautifully. Take a soak in that bathtub. There's nothing wrong with it if you can do that, right? And just make sure that you have things like warm blankets and socks. They're small strategies that have been used for centuries, that can help with pain, help with symptoms around pain. There's nothing wrong with utilizing those.
Yeah, that's really helpful to hear that there are multiple strategies and also there's a tiered approach to medication. And just a reminder to remove causes of stress if that's possible at all. Yeah, thanks
Yeah.
for that. What about neuroendocrine tumors in the bone that are causing pain? This comes up frequently. What can be done about that?
Yeah, so there are obviously treatments that are procedural, like radiation, things like that, that can help with some of those tumors, right? But when you look at bone pain, again, there are certain medications that can help with bone pain, certain medications that are non-steroidals, things like Aleve, Celebrex, these, or even just plain ibuprofen, these work very well on bone pain. That's important. The other thing is to make sure that you are enlisting in physical therapy, because physical therapists actually can work with you on making sure that your joints are appropriately working, and making sure that you're not stressing your joints or your bones more than you have to. What people don't realize with any kind of cancer that affects the bones, the way that you as a patient adapt to it, your walking style might change based on where your pain is, where the bone pain is, or where the tumor might be, right? That means that your body's adapting, and then that becomes your norm. What physical therapy does is it helps you sort of recenter what should be your norm based on where your disease is or where the pain is. And I think that's important. You don't want an abnormal to become the normal in the face of disease. Still want to create some sort of baseline. So working with physical therapy is really important when it comes to bone pain, along with medications, of course.
Yeah, that's interesting. Thanks for that reminder about physical therapy and how we can maybe strengthen ourselves to address the pain. What about depression and anxiety? What recommendations do you have to manage that?
We could spend 2 hours just on this, but I don't know a single person who got diagnosed with NET or cancer that has not gone through depression or anxiety. I think just the words of cancer itself cause chaos and anxiety in your system. So that if anyone says that they don't have depression or anxiety as they've faced cancer, obviously is we know that they're hiding behind that. Depression and anxiety are very common in these patients. So a couple of things that I say is that first of all, talk to your primary care doctors and talk to your primary care specialists, your palliative teams, and your family members about these symptoms. Because if you keep depression and anxiety to yourself, it's only going to get worse. So it's really important that you bring these to the forefront and let them know that you are facing this and that you might need some help in facing this. Once you've done that, your primary team can probably prescribe some medications for depression and anxiety, and if those are not enough, they can actually refer you to psychologists and psychiatrists that can help manage these for you. Most of the times, the challenge I have with my patients is that they are afraid to talk to a psychologist or a psychiatrist, thinking that, people say that psychiatrists and psychologists are for people that are crazy. And that's far from the truth. What I tell them is that you have a different lifestyle now. You have cancer. These psychologists and psychiatrists are going to help you cope and manage that disease. I'm not sending you to a psychiatrist or a psychologist because I think you're crazy. I'm sending them to you so that they can become part of your coping team and help you through your journey. So there's a big difference. Again, the stigma around psychiatry and depression and anxiety are so deep rooted in society that first we need to have the open conversations with our patients. We need to correct their misconceptions and misunderstandings, and then we need to guide them to the appropriate specialist to address these depression and anxiety aspects of healthcare.
Thank you, Dr. Banerjee. Another common complaint is something like this. I feel tired all the time. Is there something I can take to give me more energy?
Of course, there's always something you can take, but my first recommendation is going to be you need to assess what's making you tired all the time, right? Is it your disease progression that's making you tired? Is it a lack of nutrition that's making you tired? You're not eating enough, you're not getting enough sleep, you're too stressed out, and that's why you're tired? Or is it just the physical exhaustion of the disease that's causing you the tiredness, right? So the first step is to really assess what is at the root of the tiredness and fatigue. The NCCN just put out a new guidelines for fatigue management in cancer patients. I am the vice chair of the panel, so I will tell you that there are so many modalities for tiredness, all the way from simple strategies like improving your sleep hygiene, your nutrition, to looking at exercise to help with that tiredness, making sure that you have other aspects addressed like depression that can also cause tiredness, to medications that are stimulants that can help with restoring some of that energy. But the important thing in all of this is that looking at the whole picture of what's causing you the tiredness to get you to have the most optimal energy and the least side effects from medications that you may have to take.
Mm. Yeah, I think we all wish for a magic pill, and you're saying that to look at the big picture. Yeah.
Absolutely. There is never a magic pill for anything. I wish there
Don't
was.
we wish? We do too. What can I do to put on weight? I think this is someone who maybe is struggling with that.
Yeah, so again, weight and nutrition are something that you have to really seriously consider in not only NET but in other cancers as you are early on in your diagnoses to really as the disease progresses, right? So when you're in your optimal self and you're early on in the diagnoses and you're going through NET, you can have things like malabsorption happen. And there are many things that, nutritionists can help you with. There are certain recommendations and interventions that can be given to you. For example, supplementing for vitamin deficiencies, right? Avoiding amines and serotonergic foods, making sure that you're getting enough of a caloric content. So the first thing I would say is that if you're having any kind of nutrition issues or if you're losing weight, make sure that you see a nutritionist. I think nutritionists are underutilized and can be so helpful in the management of your disease and the weight disturbances that the disease may cause. Now, if your disease is rapidly progressing and you're approaching towards the end of the disease, and a patient is then approaching towards the end of life, you have to really take a step back and see how much nutrition is necessary for me, right? Most of the times at the end of life, if not always, too much nutrition is not a good thing, because at the end of life or towards the end of life, what happens is your body starts shutting down. And anything excess that you put in your body can go to the wrong places. Any kind of IV hydration that is put in that's not necessary for your body might go into the lungs and cause effusions, can go into your stomach, can go into your legs and hands and cause edema and swelling. And that can be very difficult and painful for the patient. So you have to always assess weight, nutrition, and the disease trajectory, right? If you're early on the disease, I think get in touch with a nutritionist, eat healthy foods, make sure that you're doing the right thing for your disease. But if you're towards the end of the disease process and end of life, then you need to reconfigure what nutrition means to you just to make sure that you're comfortable.
So there's a continuum to it. Yeah.
Yes.
So you mentioned vitamin supplementations and things. Are there particular diets or supplements you recommend?
There's not one specific thing, but I think again, the nutritionists would be best able to answer this. But for example, when you have pancreatic enzyme deficiencies, there are medications that can help supplement that, right? When there are nutritional deficiencies with vitamins can help supplement that. I think it's really important that when you have diarrhea as a result of your NET, which often is a common symptom, that you make sure that you're adding certain medications or supplements to your diet so that you're replenishing them. The important thing is that at every visit or anytime you have symptoms that can deplete your body of these natural organic nutrition or nutrients, you need to get in touch with your doctors and your nutritionists to make sure that you're on the right path to replenishing them. There could be certain diets that are recommended by nutritionists just for that small period of time, or there could be something long term that's recommended based on the type of NET that you have. And it's really important that you have those conversations. And again, I say that if you don't enlist a nutritionist to help you, this can be a very challenging course for you. It's not that easy to always manage diet when it comes to cancer and chronic illnesses. It's really important to have the right team on board to help you with that.
So the value of a good nutritionist. Yeah, thank you. What about nausea? What can be done to manage nausea?
Yeah, so nausea is something that NET patients experience a lot, and there's myriads of medications that nausea can be treated by. There's simple things like Zofran, but then we have antiemetics that are more powerful that are given to patients with a lot of nausea symptoms. We even use sometimes anxiolytics like Ativan that can actually help with nausea in patients. There's scopolamine patches, another set of medications, very similar to the seasickness patches that are given to patients for nausea. At the same time, it's important for you to assess what's causing the nausea, right? Is it the tumor itself? Is it certain aspects around the tumor? Is it the nutrition aspect that's causing the nausea? Are you unable to keep food down because of the tumor or because of the side effects of medications? So I think, again, it comes down to looking at the full picture. What is causing the nausea and what is the right treatment modality for this nausea? Does it mean that maybe you just need to you need to eat smaller meals but more frequently? Because sometimes when you eat heavy meals, that can cause nausea. So we often recommend our patients eat small meals every couple of hours so that their stomach does not feel so full and they don't get nauseated. There are many alternative things like acupuncture Acupuncture works great on nausea when it does. And it works on many other things like pain and fatigue as well. So I think it's important to explore the other natural modalities that are around you as well. There's a reason that for centuries people have survived, and none of these medications were there before. And I do believe that there's truth in some of these east west medicine complements. I think you should look at what people have used before. They say ginger is great and it helps with nausea. You know, that's wonderful. But again, when you do that, just make sure that also know that ginger has other qualities of making sure that your blood, it's a blood thinner. So you have to just know what you need to do for your nausea. But again, medications are there, and sometimes you might want to use something like a natural oil just to sort of feel a little better. Sometimes I recommend my patients use some lavender or some eucalyptus oil so that they can abate the nausea, and that helps. But there's so much available there, and you just have to see what works for you the best. Not one thing will work for everyone, so you have to find what is your treatment modality at the core.
Yeah. That's a good point. Not one thing works for everyone, and just encouragement that there's a lot out there. I know recently when my husband was started on a new treatment that was known to cause nausea, his oncologist said, medicine has come a long way in terms of the treatment for nausea. So there's no need for you to suffer. And what he went ahead and prescribed 3 different medications. Go ahead and get them filled. If it doesn't work, let us know, because there's a lot of medications out there now. So there's, the old movies where you see people in the bathroom very, very sick. He's like, you should not
Yes,
suffer like that
you
anymore.
should not suffer. I would say in most, not just with nausea, in most of the symptoms, right? We've come a long way, and that's why palliative care as a field has thrived, right? Most of the symptoms can be managed, but patients don't know that because they don't know the right person or the right specialist to go to manage them. So I think the first key is just identifying that specialist that's going to help you with all these, right? And sometimes even oncologists may not know to refer you to the palliative care specialist sometimes. So I think with all these symptom management issues, it just helps for the oncologist to partner with a palliative care specialist so that they can best treat that patient.
Thank you for that answer. And can you talk a bit about confusion or delirium? What is that, and why is it happening, and what can be done?
Yeah. So, this is again a very challenging topic, right? Confusion and delirium can happen for many reasons. One, it can happen just because your body is tired and depleted, right? And you don't have adequate nutrition in there. You can have deficiencies, you can have imbalances in your sodium that can cause confusion and delirium. You can have, which are commonly known as electrolyte imbalances. You could have medications that you're receiving for your treatment that can have side effects that can cause confusion and delirium. You can have opioids that you're taking that can also cause confusion or delirium if the dose is too much, right? That confusion and delirium happen due to many things. At the end of life, confusion and delirium happen because your body is shutting down. What can be done? Again, if it's an electrolyte imbalance, the best thing to do is replenish that with IV fluids and electrolytes. If it's towards the end of life, you can often not only get delirious, but you can get agitated. And at that point, one can give anxiolytics, one can give things like Ativan, one can even give things like haloperidol that can calm the patient down, that can reduce the agitation, because it's a side effect at the end of life that sometimes is something that can't be prevented, but we can treat it so that the patient is not at risk to themselves and harming themselves. So again, medications and alternative therapies can help with this.
Yeah. And is it something that's reversible, or is it like, does it mean something like it's the end?
Yeah. So at certain points of the disease is different, right? So for example, if you're just diagnosed or if you're not at the end of life, there's something that's causing the delirium or the confusion, right? And usually when you fix that root cause, it's reversed, right? Let's say it's an opioid that you've taken too much of that has caused confusion. You scale back on the dose and you see the confusion start going away and the opiates work appropriately. Same thing with another source that's, let's say, chemotherapy that's causing confusion and delirium. You reassess that and you possibly scale down or you remove that offending agent, and that can reverse that confusion and delirium. When it's at the end of life, it's something that really cannot be reversed because that's really in the natural process that your body is taking as your body's shutting down. And often that's something that's irreversible, but it's treatable so that the patient is comfortable as they go through the end of life journey.
Yeah, thanks for explaining that so we better understand what to expect. Is there a role of somatostatin analogs in neuroendocrine cancers as palliative treatment?
Yeah, so I mean, I think, these are pretty much, correct me if I'm wrong, these are for the diarrhea that is really a very distressing symptom in neuroendocrine tumors, right? It's palliative by using these somatostatin analogs in neuroendocrine cancers. It can really help with symptoms of diarrhea. And I think that is what we need to look at. Diarrhea is something that is a very distressing symptom for patients with NET. It affects not only where you going out, being social, but it also is something that can cause a lot of pain, and it can make you fearful of what to expect and when you'd be having your next bout of diarrhea. So I think the role of somatostatin analogs in a case like this is really helpful if they can help sort of prevent or help with the symptoms of diarrhea. It can enhance then the quality of life that the patient has overall.
Yeah. Yeah, they can be used to treat any type of hormonal symptoms. So whether it's diarrhea, flushing, if someone has a functional tumor like a gastronoma.
Exactly.
So,
Right. And you're
okay.
looking at basically all the gastric stuff that's happening, right? And so it's really
Mm,
important. Absolutely. I mean, for any kind of, I would say the carcinoid symptoms that you get, which is exactly what you're describing, it's something that's used.
okay. So that can be used as palliative. Um,
Yeah.
so I know that you help lead the caregiver support group, and we have these discussions, but what recommendations do you have for caregivers to best support their loved ones?
Yeah, so like I mentioned in my presentation, I think caregivers are a really important aspect of net care. And I think the biggest issue I find that is that caregivers really sometimes take on 100% of that role, where they really become burnt out and they aren't caring for themselves. So one thing we've all understood with experience is that, if you give 100% of yourself to something or someone, you have nothing for yourself. So the first advice I give caregivers is that we know that you want to be in that caregiving role. You know that perhaps you may be the only one who can be in that caregiving role. However, it's really important for you to define what that caregiving role means for you. And it's important to have a conversation with your loved one who's going through NET, what that expectation should be for both of you as a caregiver and a patient. There should be boundaries that should be drawn. Caregivers need time to heal and care for themselves because often they are going through similar emotions as the patients themselves are. They may not be physically going through pain, but the pain of seeing your loved one suffer does cause pain in a caregiver. There is this anticipatory grief that occurs. There is mourning for what happens to your loved one. So the caregivers also need to be cared for. And I think I often tell caregivers is to identify time and activities for themselves so that they are practicing in their own mindfulness. I often tell caregivers that they need to identify caregivers for themselves because if they suddenly have no one to care for them and they need that care, who's going to care for their loved ones? So it's important that they take care of themselves, that they have backup systems, and that they have some time to themselves throughout the caregiving process. The whole idea with with caregiving and net is that oftentimes it's not a short-term thing. Net can go on for many years, and so it's the burden of caring can get exhaustive for some people, and those people that have failed to define some time and space and healing for themselves through the caregiving process are the ones that get burnt out the fastest, and then they may not be able to care for their loved ones. So it's really important that they take care of themselves. They find support groups, and LACNETS has an excellent one, but they find support groups within the communities, within the healthcare communities, and with family and friends around them.
Yeah, thank you. Yeah, caregivers need care too. So thank you for that. You mentioned boundaries. Do you have any practical advice about how to approach difficult conversations like boundaries, advance directives, end of life issues?
Yeah. So I will say anyone 18 and over, healthy or with any kind of disease, should really have an advance directive. It's the best thing that you can do for yourselves and your family members, because we know that doing an advance directive when situations are difficult only makes conversations more stressful and can lead a patient and family members to make the wrong choices. So it's really important that when you get diagnosed or when a loved one gets diagnosed, you do start having these conversations. And the best way to approach it is just to be honest, saying, hey, look, it's as simple as saying, hey, look, this has happened to us, this has happened to you. Why don't we both take a look at both our advanced directives so that we make the right decisions for you and me? I wouldn't do it immediately, the day of your diagnosis, but I give yourself a couple of weeks or a month to get a grasp around what's happening to you and your loved ones. But then think about the future, think about your family members, and have the conversations about really, now that you have this disease, I want to understand what's important to you. I want to understand what you want me to do when the time comes to do it. And it may not be at the end of life. It just could be that, a patient has, let's say, a treatment and a side effect, and then they get admitted for some reason. You want to make sure that you understand what they want and what their wishes are so that you can make the right decisions for themselves. These conversations are more about, I want to best represent you when you can't represent yourself. So help me do it. And let's come up with a plan to do it. And at that time, the best thing is if you, as a caregiver, don't have an advance directive yourself, it's the perfect time to partner together and make one for yourselves, right? So you do it together, so it becomes less scary. And review
That's a good
your
point.
advance directive often, I think, because disease can change fast. I think it's really important to review these advance directives and bills often during your process.
Yeah, that's a good reminder. You mentioned, you've kind of touched on this a little bit about power of attorney. Can you explain what that is? I know people often says, I have someone who does this for financial reasons. Is this the same thing? And how does someone decide who this is?
Yeah, so a power of attorney that takes care of your will and your real estate and all the aspects of your estate planning is very different from someone that is a medical power of attorney. And I'm assuming that you'd want me to talk a little bit more about that. So, medical power of attorney is someone that can represent you as a patient to make decisions for you when you do not have the capacity to make decisions for yourself. For example, let's say that you are in a coma, or let's say that you're incapacitated for some reason for even a short period of time. Um, when a medical decision needs to be made, we often go to the medical power of attorney that has been assigned by you because you know who represents you best. And it does not have to be anyone in the legal system. It can just be someone in your family or your friend circle that you trust to make the right decisions for you. And these people will be called upon to make decisions for you, whether it is, taking you off the ventilator or giving you certain medications, because at that point, they are the ones that are making decisions for you. You are the one who decides who your medical power of attorney is. When you don't decide it, then the healthcare team takes it upon itself to work together to make the right decisions for you. But a medical power of attorney could be your wife, could be your friend, could be your daughter, could be anyone or the individual that you feel is going to make the right decision for you when you don't have the ability to do so. It's really important when you do your advance directives that you identify this person. And many times it's not the wife, it could be a sister, it could be a friend, it could be someone totally different than what we thought it would be. So the other thing I always often tell patients is to make sure that the medical team knows who their power of attorney is, whether when they're healthy, because you don't want the wrong person to be called on by the medical team to make these decisions. It's important to document this power of attorney in your advance directives and with the medical records that you have at the hospital that you're getting care at, so that the right person is called upon.
You mentioned that if you don't have a medical power of attorney, then it's decided for you. And how is that decided then if someone doesn't have one?
Well, yeah. So usually the first thing we'll do is we'll go to the next of kin that's there, so the closest relative. So if in that case, if it's your wife, it's your wife. If it's your daughter, right? Whoever's there, the next of kin. If it's a complicated case and there are decisions that are not straightforward, often the ethics committee at the hospital or the health system will get involved to look at what's the right decision. And often the next of kin, who is identified by the medical team, and the medical team themselves will come to a decision for the patient. And if those decisions are in contradiction, then the ethics committee will weigh in on what needs to be done at that point.
Okay. So there's an ethics committee that might help. Okay, thanks.
Yeah.
This question comes up frequently, and it's not uncommon for someone to have young kids even. What tips do you have for talking to kids about cancer?
This is something that I get asked all the time, and I think recently I have gone through this myself, and I'll tell you, it's never easy to talk to a kid about cancer. I think it's really important that we look at the age of the kid and to see the emotional maturity of the kid, and then decide how we're going to discuss cancer with that child. Some kids are very resilient and can take the news. They understand things. We should never assume that kids don't know what's going on. They may hear words around, and sometimes they might just not question it, but they understand what's going on to some degree. And I think it's important for us to understand what they know. So asking them what they know, and then figuring out how to explain to them what they need to know, right? They don't need to know everything, but when kids hear that their parents have cancer, it's something that is scary. It's not a word that people don't get scared of, and kids get scared of it. So it's important to talk to them about really what cancer means, and that your loved ones are still here. Nothing's going to change for the child in terms of how much they're loved and how much they're cared for. Things might change a little bit with caring for the patient or their loved ones that have cancer, but at the end of the day, these are their kids, and that should never change. That relationship needs to be protected at all costs. Most healthcare facilities also have child life specialists that can talk to children at their level and explaining to them really what cancer is. There's psychologists and psychiatrists and physical and social workers that can talk to children and really speak to them in a way that they can mitigate some of the fears that they may have. Also understand that sometimes children can open up to others more than they open up to family members, or vice versa. They may not want to talk to others, but they may want to hear it from you. It's really how your kids are, and the comfort level that you have. I often find it's the adults that are uncomfortable with talking to kids about cancer. And I think that's the first thing you need to decide as an adult. you need to take a step back. You need to discuss this with yourself as a patient and with the caregivers around you as to how you're going to talk to your child about cancer, talk to kids about cancer, and how you're going to assure them that through it all, the love, the support, and the family is still there. That's the most
Yeah,
important thing.
being really intentional in this process. Yeah, thank you. I'm going to end with this last question. I've heard this asked several different ways, but as you know, this is a journey that has a lot of anxiety. It feels very overwhelming, very scary. It can be really heavy and difficult. And many people will say, is it possible to be hopeful? How does someone hold on to hope? Do you even need to? How do you answer this?
It's very difficult, and unless you're in it, it's very hard to know it. Um, there's always hope, right? There's always hope for tomorrow. There's always hope that a new treatment might come across that might be the magic pill, as we discussed. There's always hope that you wake up tomorrow to your kids being there and hugging you and holding you. You always hope that next day your symptoms are a little less troublesome than they were today, right? You can always hope the sun will shine the next day. Hope is very individual, and people can get hopeless in the face of adverse disease and chronic and serious disease. And it's really important that you reassess hope. Hope is something that you find within yourself. It's the beauty of what keeps you going. And not necessarily does hope mean that there will be a cure to your disease or there will be a solution to some problem. But hope is what gets you to that finish line. And for each of us, that finish line is that end of life that we will all face. We're all mortal. Disease makes it very difficult. Disease brings our mortality face to face faster than it should come. It brings the idea of end to a realization sooner than it should be, right? But what's important is to hope that till you get to that end, that you need to do the best you can to have the best quality of life, to be there, loved and supported by your family members, to breathe the air that you can every day, to enjoy the small things that make you happy. You should never give up hope on the small things that make you happy. The small things add up to the big things, and that's what makes life. So, hope is something that can be something that takes you all the way to the end and should never be given up, ever. At least that's what I look at it as.
Yeah, yeah, it's powerful, and it can feel like it sustains you or it's air. Well, thank you so much, Dr. Banerjee, for sharing so many insights, practical tips, just for letting us hear from your expertise and your wisdom. We really appreciate you. I think you helped demystify this topic, talking about death, dying, and all the symptoms, and not just the physical aspect, but of course the emotional, mental, spiritual, all the things that contribute to our quality of life. So hopefully, I know I've learned something, and I think the audience has as well. But we really thank you for all that you do on behalf of the NET patient community.
Thank you so much. And I am forever grateful to you and the LACNETS community. And I'm always here to help you any way I can. And it's my honor to work with you and the patients. Thank you.
It's our honor to have you in our community, and we are very much grateful to you too. And now I'm going to send it back to Heather in the studio. Thank you.
Thank you.
Thank you again, Dr. Banerjee, for your important, informative, and compassionate presentation, and for answering specific questions on all facets of palliative care. In my mother's journey with pancreatic neuroendocrine tumor, I personally wish we had engaged palliative care earlier and not just at critical junctures. The expert palliative care physicians made all the difference in my mother's comfort and well-being. Their care and guidance was so important for me and my whole family. We appreciate our sponsors, Novartis, Ipsen, Crinetics, Curium, ITM, and Exelixis. Educational programs like today's are also made possible by donors like you. Please consider making a donation today at lacnets.org/donate. And a special thank you to our technical director, Rich Tamayo from TVP Live, for this high quality broadcast production. Follow us on social media to stay up to date on our upcoming events. Our handle is @LACNETS. And now I'll turn it back over to Lisa.
Thank you, Heather. LACNETS is a community of support and resources. We recognize that you are more than your disease, and we aim to support you as a whole person. To this end, we offer many resources and programs. Find out more on our website, lacnets.org. LACNETS has a monthly podcast featuring experts who answer the top 10 questions in their field. Go to our LACNETS podcast page to check out the episode transcript, resources, and the 10 questions we asked the expert. Thank you again for joining us for today's educational event. We look forward to seeing you on December 10th. Goodbye.